Yep.
All right. So first, I wanted to just do a little reflection on the health literacy being recognized as a driver of health inequities and how that depends on mediating factors, including the reading skills, level of education, knowledge about preventative healthcare, and the ability to access and use health information effectively. It is estimated that on average, patients do not recall half of the health information communicated during visits. And this number seems to be higher with those with lower levels of health literacy. Accessibility, obviously disparities reflect interrelated factors that include issues of accessibility, and with the focus on patient-centered care and transparency, the Open Notes movement can play an important role in improving the healthcare for vulnerable populations. Mentioned some surveys. I have references so you can find the resources for this. I'm gonna skip some because I think we don't have enough time. One important point for me was that less educated and non-white patients seem to assign higher importance to reading notes than highly educated and white patients. So, I think finding transparency especially valuable is a point that we have to take into account. However, literacy disparities and the digital divide can widen the health inequalities. So many have raised concerns about how this divide may increase such inequities, and collaborative documentation could be a way to improve our ability to engage patients with different backgrounds in this transparent way, regardless of the opportunity for these patients to access their notes through electronic records. So that's kind of a reflection to put it in context. Therefore, could we use collaborative documentation with this purpose? What is collaborative documentation? I took this nice quote from Sandy Blount. It felt to me that sometimes we are in this parallel play with the patients where we don't really confront much of the information that is in our minds in order to get it to the node. So maybe we have to start playing collaboratively and be more developmentally advanced for the node writing. So collaborative documentation might be seen as a process and an outcome. Patient and clinician collaborate in the content, but also through the process of the whole session and interventions in real time along the session. So it's not only a product, but it's a process. It implies some level of parity between the two parties sharing a common task. It gives patients the chance to actively participate in the design of their care, therefore it's a partnership. It is also a negotiation to incorporate the patient perspective into the assessment, the plan, and the progress of treatment, and through a negotiation based on open mutual feedback. It could be seen as a bridge, lessening the gap between the knowledge and language of patient and clinician, and I think that's in both directions, where we learn the language of the patient, but also we sometimes teach patients how do we call certain things in the field, which is also cool. The most important part for me is that it is an intervention to unify discourses that we use with patients and colleagues. So writing with the patient versus writing about the patient. Is a clinical tool in which we could build trust in the partnership and confidence in the ability to improve, as well as compromise to work towards common goals, and mutually enhance motivation and align expectations. It's a self-care tool. You guys were talking about this today. It brings the possibility to do most or all the note in real time, no catching up with notes. Completed with patient also brings the opportunity for less misunderstanding and future surprises with patients. So in that way, it's a self-care tool, but also a risk reduction strategy. We could add to our notes, the content was reviewed with the patient before signing the note. And this is important for a lot of people who are really getting very anxious about the open notes in terms of liability and all those implications. I guess I have to skip the examples unless you tell me otherwise, because I just stay with the tips and skip the examples. So I think it's helpful to start when it feels easier with patients that have already been existing patients and you feel you have a connection with. Breaking it down into segments is helpful rather than waiting to the end and write a full note. Offering it as an opportunity rather than a task. I think when we recommend this to clinicians, sometimes people who don't really get to buy into it, they sell it to patients in a way that is not exciting to anyone. So less chance to get the patient to buy into. Anticipate questions and always offer to opt out. Maybe preparing some scripts you're comfortable with that you can tailor to different ages is helpful at the beginning. And present it as a creative task or a game when that is appropriate to age and circumstances. So I have 4 examples, 4 steps that maybe when you introduce the idea, that's a moment in which you document that piece. Then after you assess or reassess the presenting problem, you can stop and get again and reflect with the patient after an intervention. And at the end of the visit, at wrap up when you discuss the plan and possible homework or tasks. So these are the 4 scenarios that I think I will skip for the sake of time. I had scenarios for young kids, for parents, for teenagers. Perhaps the only one that I think is worth mentioning is when there are some issues that need to foster collaboration with the parents and the child or perspective taken. I think it's a good way also to diffuse the tension when there is a certain conflict about negotiating the goals. But you can read them when we send the presentation. And of course, it will not work for everyone. Some people prefer parallel play. And I think a different way to do this is some people find it helpful to process on their own after the sessions, and they don't want to finish a note just right after when the session ends. So I think we could just read the notes to the patient when this next session starts. I think is equally helpful for the sake of transparency and be on the same page, even though it's less collaborative. And also, you know, the part of unifying discourses changes the patients, maybe for activation and other things, but I think it changes our practice as well for more transparency and accountability. So that's it. I'll stop sharing. I know we don't have much time, so sorry for rushing. So I know there were some people on the call last time when we started talking about this that have already been doing collaborative documentation and had great thoughts about it. So maybe someone wants to share that.
I have a few thoughts. Gunderson's gone live with this open notes, gosh, October, I think is whenever our health system did it. And so I just thought as you were talking, wow, I wish you had presented to our BHCs about this as we were bringing this information to them, because I think, you know, you really did such a fantastic job at highlighting the positives, both for the provider as well as the patient, that we tried to get to, but I think was really hard to get to when messaging was a lot of fear coming back, I think, from providers. And so I think that the way that you presented this was really, really great. And I think your system would probably benefit from you doing this presentation there if you have not already. But I think that it would be something great to share share really broadly, and I plan to steal some of these things as we continue to go through this process. You know, it's been almost 4 months, and we still get questions about it. Less than I think were anticipated at the beginning of going to open notes, but certainly it still comes up, particularly with pediatrics patients are the ones that I hear most about, even though I have providers seeing adults as well.
Right.
But this was fantastic.
Thank you so much.
Could either one of you talk some about like some of the barriers that have come up with trying to use that and how you've overcome them? Because this is a great, thanks so much for presenting on this. I think it's a really important topic.
Ali, do you want to share with the implementation?
Yeah, so we had planned to go live a week before this was nationally going live, and then it got pushed, and Gunderson went live anyway because they had put everything in place. I think behavioral health, we're housed under behavioral health department, and so I think the behavioral health department had a lot of anxiety about this going live, and then I think the BHCs did as well, just given the sheer volume of patients that we see compared to our outpatient behavioral health partners. And same thing with pediatrics. So I think pediatrics then added another layer to this. And so what notes of pediatrics would be going live, and how Gunderson formatted that was adult notes, all historic notes are now live and able to be read. Pediatrics notes, it was from the go live date. So from October, I'm blanking on the exact date that we went live, but from October on, the notes are live. And when the patient hits 18, all of their previous notes are live. So, and able to be read by patients. It was interesting because I think that there was a lot of talk among providers as to not necessarily sharing this with their patients, and saying like, hey, now your notes are going to be live. And there's a lot of concern about if I share it, then they're definitely going to read them. And so we stood up and took a very different approach with our integrated care team and said, nope, this is part of consent. And so we'll be sharing this with our patients so that we can do exactly what you've been talking about, Chus, of how can we collaboratively document with patients. And one of my goals as a BHC is to have my notes done before the patient leaves the room anyway. And so it was doing a lot of this already, but now I'm doing it, I think, just more transparently than I was before. So I actually think it's been a really good practice change. There have been some concerns that I've had with patients that their parents can see their notes. So I work in a gender clinic, and so I'm working with some transgender patients and they're not out. And so that's certainly been something that I've taken into consideration. Or abuse exams are another thing that I sit in a lot of. And so there are specific instances, and Gunderson has worked that out with it. We have a trauma-informed care note. So there is a note type that you can put in, and then your documentation does not go live unless explicitly requested through our specific admin means. So there are some specific pieces that we've put into place to try to protect those patients, and I'm always very transparent with my patients about that as well. So given what we're here seeing and talking about today, it feels like this would be the most appropriate kind of documentation for you. And so going through that has been really helpful. But yeah, that's just what I'd share kind of from our little snippets that we've picked up on so far.
Yeah, in our clinics, I think there was a lot of barriers coming from clinicians, because we have a lot of clinicians who are working in a psychotherapy mode. And so it's hard for them to conceptualize some of these things without changing a lot. But a lot of people took it, like a good change. I think the biggest barrier is doing it through telehealth, because some of the pediatric tips are nice to do with the kid in person or the families, like showing your screen. And I have one of the examples, like with the smileys, that you can put the kid to play with that with you. And we cannot share a screen in Epic in our organization because it's a safety feature that is blocked. So it is huge in general for pediatric clinicians to work without the ability to share a screen with kids, but with this particular aspect of collaborative documentation even more, because it implies that then you have to read it if you really want to stick to it collaboratively. So those are tech barriers that we cannot overcome. I know Cody has the same system, but they have the the feature of screen sharing available to them, which I'm very jealous of, but we do.
We do, yeah. The screen sharing does make it nice to just pull up the note together and kind of walk through it. I use it as one of the things that I really like that you put is like, how does this work for you? Because I think there's like several intervening parts of this talk, and one is the Cures Act and the open access. One is collaboratively working on the notes together, and another one is like this efficiency kind of piece too. And you know, we're moving to more 30-minute appointments and things, and it's really helpful to allow your note to guide an agenda set for the visit, which we do a lot of. So we sit down and talk about the agenda, which is part of the note. We write it down together so we can both agree on it. We do our update on functioning right there, and I type it to make sure that that makes sense and is accurate. And we kind of put the computer away for a little bit and we talk about the interventions and we practice and teach. And then what I usually do is I have my patients do a teach back, or the parent or the patient do a teach back. And as they're doing the teach back, I tell them, I'm going to write down what you say. So that way it's in your words. When you go home, it's in your words, you understand what I say, rather than it being in my words, which you might not understand. And so I'm going to take some time to type it, not because I'm not paying attention. I just want to make sure that this is going to make sense to you when you go home. And then I type up everything in our plan, and then my note's done. Because I think the other intersectionality piece with this conversation is probably the difference between a process note and a progress note. And we've been trying to get a lot better too about writing progress notes, not process notes. And this has really helped us serve all of those functions, getting our documentation done quicker, writing more progress rather than process notes, and doing some of those other things. So it's been a wonderful process once you frame how does this work for you, rather than the scary thing that's happening to you.
Yeah. I always thought that, you know, framing the equity piece is important too, because no one wants to go against equity, right? So when you try to convince clinicians that is good, it's a nice way to introduce.
Mm-hmm.
I'm sorry, I have to hop off. I have another meeting, and it's my organization's meeting, so I cannot miss it.
No, we
Thank you
appreciate
so
your
much.
time. Yeah.
Thank you.
Thank
Take
you.
care.
This was really good.
Bye-bye.